Thank you very much for the opportunity to share with you really attractive data that has been developed in this clinical trial. But let me start with some flashes, key points about the story of multiple myeloma. As you can see, the first myeloma patient was diagnosed in 1846, but it was not until 1958 that the first active anti-myeloma agent was discovered by Russian doctors, but published in an American journal. Corticosteroids were added, and in the following 40 years, no real advances in pharmacology for myeloma were obtained, because in fact, the only step forward was autologous transplant that is based on high-dose Melphalan. And for patients not candidate to autologous transplant, Melphalan and Prednison was the only option. After year 2000, things has changed dramatically. 9 new agents had become available. In 2008, we published a first study in which the standard of care until then, Melphalan Prednison, was challenged by the addition of a proteasome inhibitor, Bortezomib. The VMP regime showed an improvement of more than 1 year in not only progression-free survival, but also overall survival. And since then, Bortezomib Melphalan Prednison has become a standard of care in many countries. It is interesting to see that coincidental with the publication of this paper in New England Journal of Medicine, the first myeloma patient dosed with Daratumumab has occurred. And this is the reason why we are here today, because Daratumumab is an anti-CD38 monoclonal antibody that has shown high activity as single agent in highly refractory patients, but extremely active in combination with other drugs, always in the relapse setting. Today, for the first time, we are going to see the results of Daratumumab in newly diagnosed myeloma patients not candidate for autologous transplant, elderly myeloma patients. And what we have done is to compare that standard of care, Bortezomib Melphalan Prednison, 9 cycles, versus the same schedule, but adding Daratumumab, and then continues with Daratumumab until progression. As I mentioned, this study was concentrating only in transplant ineligible patients. This is the position of the patient. A total of 706 patients had been included in both arms. Median age, 71 years. 1/3 of the patients over the age of 75. 1/4 of the patients with clinical score of 2. Stage 3 in 36–41% of the patients. High risk cytogenetics in 16% of the patients. In other words, real-life active myeloma patients with advanced disease and elderly population. The primary endpoint of this study was progression-free survival. And after a median follow-up of 16.5 months, the results show a significant reduction, 50% reduction in risk of progression of death, with median PFS of 18 months in the control arm and not been reached yet in the D-VMP. Why this benefit? You can see the explanation is clear in the right part of the slide. Responses, 91% versus 74%, but what is more important, depth of response. Double complete response rate were obtained in the Daratumumab arm, 43% versus 24%. And even more relevant is minimal residual disease. 3-fold higher minimal residual disease negativity rate was obtained in the Dara arm. Why I emphasize the minimal residual disease negativity is because we know now it has become probably the most relevant marker for prognosis in multiple myeloma. And in fact, as you can see in the curves, patients achieving an MRD negative status, even in the non-Dara arm, as well as in the Dara arm, that is 3 times easier to obtain, saw a significantly longer progression-free survival. In the MRD positive, data also significantly improved the survival. What about safety? Treatment was very well tolerated. Infusion reactions occur mainly in the first course of treatment and usually grade 1 and 2. The only difference was infection. A slightly higher incidence of infections and pneumonia were observed in the DARA arm, but only 1.4% and 0.9% of the patients, respectively, discontinued treatment due to infection, and only 1 patient per arm discontinued treatment due to pneumonia. Then, in summary, I think these results clearly indicate for the first time that in a phase 3 randomized study conducted with a monoclonal antibody in newly diagnosed myeloma patients, the addition of Daratumumab to a standard of care reduced the risk of progression of death by 50%. And this is associated with significantly deeper responses, including 3-fold higher MRD negativity rate. There was no new safety signals, and except for higher infection event that resolved. Finally, there are several additional ongoing frontline Daratumumab studies, including combination of DARA plus Lendex, DARA plus VTD, DARA plus VRD, and DARA plus CyBorD, in order to establish for everyone new standard of care based on a monoclonal antibody upfront. Thank you very much for your attention.